right. Well, thank you very much. Without further introduction, I think we've covered a lot with Dr. Chuhan, other than to maybe mention that he's been named one of the 50 under 50, or will be. I don't know if that's announced yet, right?
It was announced this month. Thanks, Bob.
In Lexington. All right. Well, thanks, Dr. Chuhan.
Bob, a quick question before I move forward. How do I advance the slides? Is there a tab to click?
You will be able to advance them just by hitting your enter button or by hitting the forward and back buttons.
I see. Perfect.
Good.
Gotcha. All right, guys. Good morning, everybody. Actually, sorry, good afternoon. Thank you for having me here, and Ken, Bob, Marianne, and giving me an opportunity to talk about a topic often not discussed in neuroendocrine cancer meetings because it is a relatively rarer subset of neuroendocrine cancers called high-grade neuroendocrine carcinoma. And today I would be giving a brief primer about high-grade neuroendocrine cancers, what they are and how they differ from our commoner low-grade well-differentiated neuroendocrine tumors. My name is Chuhan. I'm one of the medical oncologists at University of Kentucky Markey Cancer Center. I'm a director of neuroendocrine tumor theranostic program, and as mentioned before, about 50% of my practice involves with high-grade neuroendocrine cancer and the other 50 low-grade well-differentiated neuroendocrine tumors. These are some of my disclosures. As you all know, as compared to common cancers, colon cancer, breast cancer, prostate cancer, the incidence of neuroendocrine cancers has been on the rise. And that's a very consistent trend since 1970s. Incidence means the number of new cancer diagnoses for that particular, for example, neuroendocrine tumor in that particular year. When we look at the prevalence means overall number of patients with one particular diagnosis living with that diagnosis at any point of time. And as you can imagine, prevalence of neuroendocrine cancers even more impressive as many of the patients live for several years, several decades, which is a good news. So overall, the prevalence of neuroendocrine cancer is significantly more than a lot of other GI cancers that we know of. We have seen similar trends in Kentucky. When we reviewed our Kentucky Cancer Registry database, our rates of neuroendocrine cancer incidence and prevalence were much higher than national averages. And that's really why I'm dedicated towards researching neuroendocrine cancers, hopefully understanding these cancers better and come up with better treatment options. But today's topic is high-grade neuroendocrine cancers. So before we delve into more specifics, let's acquaint ourselves with some common terminologies. Neuroendocrine cancer is not one disease. It's a spectrum of different diseases. So let's talk about neuroendocrine cancers of lung. In lung, we often classify neuroendocrine cancer based on their grade and morphology into slow-growing, low-grade cancer like typical carcinoid. Somewhat little bit more aggressive than typical would be atypical carcinoid, some dedifferentiation. And at the very extreme end of the aggressiveness would be high-grade, poorly differentiated neuroendocrine carcinomas, which are primarily of two major types, small cell or large cell neuroendocrine carcinoma. Similarly, in extrathoracic neuroendocrine cancers, that means outside the chest, outside the lungs, we have a similar pattern of distribution. It's a spectrum of disease. At the low end of the spectrum, it's a grade 1 well-differentiated neuroendocrine tumor, somewhat little bit more aggressive than grade 1 would be a grade 2 well-differentiated neuroendocrine tumor. And on the higher end of the spectrum, the grade 3 or high-grade neuroendocrine cancers are primarily of two types: well-differentiated grade 3 neuroendocrine tumor, NET, or poorly differentiated neuroendocrine carcinoma, NEC. It's a very important difference, NET versus NEC. And again, just like lung, poorly differentiated neuroendocrine carcinoma can be of further two subtypes: large cell neuroendocrine carcinoma or small cell neuroendocrine carcinoma or small cell lung cancer. This pie charts kind of shows us various subtypes of neuroendocrine cancers, especially in the lung. So in lung cancer, which is a common type of cancer, especially in Kentucky, we see neuroendocrine cancers together form about 18 to 20% of all lung cancers. Out of that 18 to 20%, most of it is represented by small cell lung cancer. But the other rarer subtype of neuroendocrine cancers, like carcinoid tumor of lung, represent about 2%, and large cell neuroendocrine carcinoma of lung about 3%. So together, neuroendocrine cancer do represent a significant portion of this pie. We did a small research a couple of years back looking at spatio-temporal distribution of large cell neuroendocrine carcinoma in Kentucky, and we noticed that the incidence of large cell neuroendocrine carcinoma has almost doubled in last 10 years. So now we know the spectrum of neuroendocrine cancers, and today we'd be focusing more on the high-grade spectrum of it, and primarily how we differentiate carcinoid, atypical carcinoid, a high-grade neuroendocrine carcinoma, or grade 1 well-differentiated, grade 2 well-differentiated, grade 3 well-differentiated versus grade 3 poorly differentiated, based on the biopsy, based on the histopathology. And that's the most critical element of the management of these cancers. This slide shows how a well-differentiated low-grade neuroendocrine tumor looks under the microscope with various stains and has a particular pattern, as compared to high-grade neuroendocrine cancer like small cell or large cell. It is there's no architecture, it's just growth of sheets of cell, stains very actively for Ki67. However, without going into too much detail of histopath, primarily why we need to know the path is because we classify these cancers based on this grading. And you all are aware of, and you've heard in the morning session, neuroendocrine tumors are primarily graded into grade 1, 2, 3 based on Ki67 index, and the lung neuroendocrine cancers based on mitotic rate. However, back in the days when 2010, when WHO came with the classification, all grade 3 were clubbed together, be it well differentiated, be it a poorly differentiated, be it Ki6720 or Ki6799. But in reality, we know that a patient which has Ki67 of 22 but is a well-differentiated histology does a lot better as compared to a poorly differentiated neuroendocrine carcinoma with Ki67 of 30 versus 90. And based on our understanding and outcomes on these grade 3s, WHO acknowledged that differences, and in 2017 created a separate category in grade 3 neuroendocrine cancers. Now we have two types of grade 3 neuroendocrine cancers. One is a well-differentiated grade 3 neuroendocrine tumor, and other one is poorly differentiated neuroendocrine carcinoma, which has two subtypes, small cell and large cell. Recent years have also led us to understand their molecular biology in a lot more detail. So it's not just the appearance of these cells under the microscope that helps us differentiate between grade 3 well-differentiated, the poorly differentiated. When we sequenced the DNA of these tumors, we realized that high-grade, poorly differentiated neuroendocrine cancer express a very different and distinct genetic signature. For example, they tend to have a lot more mutations in TP53, loss of RB1 proteins, as compared to grade 3, but well-differentiated neuroendocrine tumors tend to express mutational profile very consistent with other neuroendocrine tumors like DAX, ATRX, and MEN. So much so that these findings are now making inroads into the actual WHO classification, which is going to be coming out. Actually, recently came out in 2019. So the rest of the classification is very similar, but we are also incorporating our understanding of the molecular biology. So if a tumor expressed TP53 or RB1 tends to be of more poorly differentiated variety of high-grade neuroendocrine cancers. Similarly, in lung, especially lung large cell neuroendocrine cancer, which is the more commoner subtype for large cell, we do now, in reality, we often treat them like small cell lung cancer because that's the more prevalent and more studied high-grade neuroendocrine cancer of lung. However, now we know that if you sequence the pulmonary large cell neuroendocrine cancer, not all of them are like small cell, at least genomically. In fact, only 40% of these pulmonary large cell neuroendocrine cancer express genetic signature very consistent with small cell. Majority of them, about 60% of them, actually are very similar to non-small cell, like adenocarcinoma of lung. So based on this understanding, we recently started a pilot prospective study wherein we are doing next-gen sequencing of all high-grade neuroendocrine cancer up front, and this would help us stratify the upfront treatment. And we are hoping that by doing this, we will be able to get platinum-based chemo to the ones which express small cell signatures as compared to adenocarcinoma regimen of that particular site, as recommended by NCCN, if they express non-small cell features. This is a feasibility study to see if this can be done in a timely fashion, and if we see any improvement in responses, because we know that in large cell neuroendocrine cancer, the response rate to platinum is not similar to what we see in small cell. And this could be perhaps the reason, because not all of them are like small cell. Moving forward, let's focus more on high-grade neuroendocrine cancer. So what we discussed earlier is we have now two major broad varieties of high-grade neuroendocrine cancer. One is a grade 3 well-differentiated neuroendocrine tumor, and the second is poorly differentiated neuroendocrine carcinoma, which further has two subtypes, either small cell or large cell. So how do we diagnose these high-grade neuroendocrine cancers? Well, there are various ways to diagnose cancer. Blood test is one way, but unfortunately, the blood tests for neuroendocrine cancers in general are not very accurate. We can see chromogranin to be elevated in high-grade neuroendocrine cancer, but it is not consistent at all. There is another blood test called NEC, which is neuron-specific enolase, and often seen elevated in poorly differentiated neuroendocrine carcinoma. Again, it is not very consistent, and since it is not very sensitive or specific, they are not routinely adopted. However, there is certainly a role for these tests, especially when we are teasing out the biological difference between grade 3 well-differentiated or poorly differentiated. However, none of these tests are 100% diagnostic. Also, some of our other blood tests, for example, which we often do it in low-grade neuroendocrine tumor like serotonin, VIP, gastrin, these high-grade, especially poorly differentiated neuroendocrine carcinoma, tend not to be functional. They do not secrete the hormones, except for maybe one or two anecdotal cases reported in the literature. Most of these cancers are not functional, so there is no role for checking serotonin or other functional hormones in high-grade poorly differentiated neuroendocrine carcinoma. Last year, we did stumble upon a novel or a new blood marker called Progastrin, which was recently studied and validated in some of the GI cancers, but has never been tested in neuroendocrine cancers. We sent 30 samples as a pilot, and we were very surprised that it correlates with the disease burden in high-grade neuroendocrine cancers as compared to normal healthy patient population. Based on these very promising results, which we presented earlier this year at GI ASCO, we conducted a large confirmatory 100-patient study, and we had shipped 100 patient samples to Europe where the assay evaluated level of progastrin, and we are currently analyzing the data as we speak. Hopefully I can present these data in the next NCAN meeting. So while we might not have a good answer for diagnosing neuroendocrine cancers based on the blood test, imaging does help us quite a bit in understanding the extent of disease. Now, you all are aware of gallium-68 dotatate scan, which basically tells us the burden of somatostatin receptor positive disease in the body, which is often very prevalent in low-grade and well-differentiated neuroendocrine tumors. However, the prevalence or the incidence of somatostatin receptor in the high grades is not as abundant as compared to well-differentiated low-grade. Some series report that neuroendocrine cancer of GI origin can have 30 to 40% of them can express somatostatin receptor, maybe not at that high density, but they do tend to express. The study which was announced just prior to this talk, the NCAN award, is basically going to fund us to prospectively evaluate the role of somatostatin receptor imaging and somatostatin receptor IHC testing in these patients in high-grade neuroendocrine cancer. So hopefully we'll have more data. But as of now, the mainstay of imaging are CT scans and MRI for early staging and monitoring of the disease. In select cases, if at all we have to do a PET scan or a functional imaging, then an FDG PET is a more valuable scan, as unlike low-grade NETs where we tend to do gallium scans or gallium dotatate scan. The reason is the high-grade neuroendocrine cancer are very fast-growing cancers. They're very metabolically active. So FDG PET scans are often light up very bright and are a better way to determine the burden of disease. How do high-grade neuroendocrine cancer present? Now, this is this data that I'm showing is from small cell lung cancer, which is the most well-studied high-grade neuroendocrine cancer that we know of. So small cell lung cancer, we often see patients present with metastatic disease. It's very, very rare to find patient in early stage. More common presentation is metastatic or extensive stage small cell lung cancer. And a lot of patients, up to 30%, can present with brain mets at time of diagnosis. The other common places for metastases are lymph node, bone, adrenal glands, etc. When we talk about extrathoracic high-grade neuroendocrine cancers, like, for example, the commonest extrathoracic high-grade neuroendocrine cancer based on NCDB analysis is pancreatic large cell neuroendocrine cancer, followed by colon large cell neuroendocrine cancer, followed by esophageal and then rectal. These cancer also tend to present in metastatic setting 70 to 75% of time. It's only 20 to 25% patients who present with early stage, even in extrathoracic setting. And but the stark difference between the small cell lung cancer, or the lung high grades, versus extrathoracic high grades is the incidence of brain mets. The brain metastases in extrathoracic high-grade neuroendocrine cancer is less than 5%. It's very low. So that's a good thing about high grades outside the thoracic cavity. What are some of the prognostic factors which will determine good versus poor outcome? Clearly, the stage of the disease. If we are lucky to be able to catch the cancer in early stage, then the outcomes are somewhat better than as compared to if the patient does present with extensive or metastatic disease. But the baseline performance status of patients is fit to begin with, they tend to do better as compared to if they are very weak and frail to begin. And some other markers, for example, metastasis in the brain or bulk of disease, are certainly factors which will affect the overall outcome. So how do we go about treating high-grade neuroendocrine cancers? The way we treat high-grade neuroendocrine cancer essentially is very similar regardless of the site of the body. there is a role for surgical intervention only in resectable or very early stage high-grade neuroendocrine cancer. For example, patient with very early stage 1 pancreatic large cell or rectal large cell, they would get surgical resection. However, even after curative surgeries, most patients would relapse. So even with the surgical resection, it is often advised to give some adjuvant chemotherapy plus minus some radiation based on the site of the origin. The thoracic early stage are often treated with chemotherapy and radiation because we don't want to do a big lobectomy or a lung surgery only to realize a few months later the cancer came back. So it is not uncommon to go for chemoradiation as a definitive curative methodology in early stage thoracic high grades. However, there is some role for surgical intervention in select cases. As I mentioned earlier, most patients, at least in the US, based on the current data, do present with extensive disease or extensive stage disease at the time of diagnosis. So systemic therapy is the mainstay of the treatment. And primarily the systemic therapies which we often employ in our clinic are chemotherapy, immunotherapy regimens, and clinical trials. Before I go into specific treatments, the general gist of the high-grade landscape is that we really, unfortunately, haven't made big strides in terms of treatment advancements in high-grade neuroendocrine cancers. Most of our treatment paradigms are basically established from small cell lung cancer experience because that's the one high-grade neuroendocrine cancer which has been most extensively studied in clinical trials. So we often try to use our experience from small cell into other high-grade neuroendocrine cancers. But in high-grade neuroendocrine cancers of GI origin, remember outside lung, the common sites for high grades are pancreas and colon and esophagus. We often use GI regimens like FOLFOX or FOLFIRI. However, the frontline regimen of choice for metastatic high-grade neuroendocrine cancer is platinum doublet by far, because most patients respond very favorably to a platinum-based chemotherapy, and we'll talk about that in a second. Clinical trials are very much encouraged in this disease because that's the only way to improve our treatment options for the future generations. And lastly, immunotherapy has started making some inroads in high-grade neuroendocrine cancers, and we'll discuss a little bit data on that. During 1970s, the only way to treat this cancer was a cocktail of very toxic drugs, especially CAV was standard of care regimen. In 1980s, we realized that a regimen called platinum doublet, etoposide, and one of the platinum, either cisplatin or carboplatin, was equally good and less toxic. So since 1980s, this is the standard frontline regimen for high-grade neuroendocrine cancer. And that kind of tells you the unfortunate aspect of this cancer. We haven't really changed the frontline treatment since 1980s. We haven't found anything better than this. So the second drug in the platinum could be either carboplatin or cisplatin. Although cisplatin is the preferred agent in limited stage or a curative setting because some trials have shown a little bit better responses to cisplatin in early stage or limited stage disease. However, in metastatic disease, where we are not really aiming at cure because we cannot get cure, the goal is to prolong life and reduce morbidity and reduce treatment-related complications. In my experience, carboplatin is a little bit better tolerated than cisplatin, although they both have very distinct toxicity profile. Cisplatin tends to have a little bit more renal side effects, kidney side effects, neuropathy, whereas carboplatin can cause your blood counts to go a little lower as compared to cisplatin. So we have to choose the platinum based on the individual patient's risk profile. So frontline is easy, small platinum doublet. the debate is what to do as a second-line therapy for high-grade neuroendocrine cancers. The general rule of thumb is if the patient has a very platinum-sensitive disease, that means if the patient has had a response for over 6 months after the frontline therapy, we can potentially try to re-challenge them again with the platinum. These patients might still be platinum sensitive, but unfortunately, most of our platinum high-grade neuroendocrine cancer patients do relapse in a couple of months after finishing platinums, 2 months, 3 months, 4 months, and those patients would not benefit from a retrial of platinum, especially if they have relapsed within 6 months. So what do we do if somebody relapses immediately after platinum? Well, as I mentioned, clinical trials are always a good option. Topotecan is FDA approved second-line chemotherapy in small cell lung cancer. And as I mentioned, small cell regimen often are followed for other high-grade neuroendocrine cancers. I personally do not like topotecan because of the way it is given, multiple doses, and also it's very toxic in my experience. There's been a new kid in the block, lurbinectedin, recently approved just a couple of months back for small cell lung cancer, but experience with extrathoracic high-grade. Irinotecan is my go-to, another salvage regimen, sister class drug to topotecan, and much better tolerated in comparison to topotecan. I often use it and has activity in high grades. The longest I've seen, I had a patient on second-line irinotecan for close to 14 months before the patient developed resistance to irinotecan. As I mentioned before, for GI high-grade neuroendocrine cancers, many people often use the colon cancer regimens, FOLFOX, FOLFIRI. And then there has been some experience reported with these regimens as well. Docetaxel and CAV would be other regimens patient is fit enough to handle more cytotoxic chemotherapy. But I would like to highlight a class of drug which really has been the only silver lining in this whole high-grade neuroendocrine arena in the recent past. Immunotherapy drugs like durvalumab and atezolizumab have now made into the frontline treatment as standard of care in addition to platinum doublet and followed as a maintenance in at least small cell lung cancer. And other drugs like nivolumab, ipilimumab-nivolumab combination, and pembrolizumab goes by name of Keytruda, Opdivo, Yervoy, have now made into second and third line approved treatment for small cell lung cancer. So we do have some options for immunotherapy drugs in small cell regimen and has shown improvement in overall survival. However, outside small cell lung cancer and high-grade neuroendocrine cancer, we don't have any approved drug for immunotherapy unless they have high tumor mutation or intermediate or high tumor mutation burden. There was a recent FDA approval for any cancer type which has tumor mutation burden more than 10. It could be any cancer. And I often see that there is a subset of high-grade neuroendocrine cancer patient which has high tumor mutation burden. Now we can offer them on-label Pembrolizumab, which was presented at AACR, a national cooperative group multi-center study called SWOG-DART study, which used immunotherapy doublet, ipilimumab and nivolumab, in various rare cancers. It was a basket studies with various baskets, and one of the study basket was neuroendocrine cancers. They did have experience with 18 patients of high-grade neuroendocrine cancer and found that 44% patients responded. This waterfall plot, the bars which are hanging upside down, shows these many patients actually had tumor shrinkage on the study, which is definitely very promising and exciting because we often don't see results like this in high-grade neuroendocrine cancer. So it's very promising. So based on these data from small cell lung cancer and now early data from SWOG-DART study, I think immunotherapy has made inroads into high-grade neuroendocrine cancers. Unfortunately, for extrathoracic high-grade neuroendocrine cancer, it's still not on label, so many people try it as off-label. My personal preference is always a clinical trial with immunotherapy drug for high-grade neuroendocrine cancers. And that is my segue into the last two slides. So as I am dedicated to advancing therapeutics for especially high-grade neuroendocrine cancers, one of my first trial that I started last year was a small cell lung cancer trial where all the patients who get the platinum-based chemotherapy and has platinum-sensitive tumor, we are offering them maintenance with a PARP inhibitor and immune checkpoint inhibitor, nivolumab. The PARP inhibitor used in the study, the induction chemotherapy platinum doublet causes the DNA damage. And by giving the PARP inhibitor, rucaparib, we prevent the cancer cell to heal its DNA so it stays in remission longer. And we add nivolumab because we know immunotherapy does help and prolong overall survival in small cell lung cancer in frontline setting. This study is accruing very well. I'm really hopeful that by next year, October, we will complete the enrollment and disclose the results. Based on what we see in the high-grade small cell of lung origin, the activity of rucaparib nivolumab, I don't see a reason why we cannot replicate this in extrathoracic high grades of GI origin if we see some promising results. So stay tuned, friends. The other studies which I'm really excited about, high grades, and we have it open at Markey Cancer Center, are the study which I mentioned earlier, the frontline NGS-directed treatment of high-grade neuroendocrine cancer based on genetic signature of TP53RB1 getting platinum versus adenocarcinoma regimen per NCCN guideline. There is a study developed by NCI CTAP, uses three drugs, ipilimumab, nivolumab. These are immunotherapy doublets, which have already shown some promising data. Then you add cabozantinib to it, becomes a triplet. And we know when you add cabozantinib to immunotherapy, that the effectiveness of immunotherapy does improve. And we know this from early phase clinical trial in bladder cancer. So this study is now open at various sites. We have it open here. I'm very excited about this study for our high-grade neuroendocrine cancers. Besides that, we also have studies looking at small cell high-grade subtype, any site of the body. One of the studies using topotecan plus a new drug called ATR inhibitor with the same rationale that topotecan tries to kill cancer cell by destroying its DNA. And the new drug, the ATR inhibitor M6620, tries to prevent the DNA repair, so keeps the cancer cell in remission longer. So we have numerous studies targeting high-grade neuroendocrine cancer, both well-differentiated, poorly differentiated, large cell subtype, and small cell subtype. And I really encourage all my colleagues as well as patients to help advance science, because this is truly an area of unmet need. With that, I'd like to thank you all for listening to my talk, and I'll be happy to answer any questions.
Yes. Well, thank you, Dr. Chuhan. That was definitely some exciting news, all the research that you've done already on high-grade nets. So right now we're waiting for Dr. Zaks to get into the room, and while we wait, I'd like to just check in on one thing. And I think Markey is part of this as well. I know that Enterade is looking to get a study going, evaluating it as a medical food, and I know it hasn't received approval yet. So nobody's going to be speaking about it except for me, because I'm not involved with it. I'm just a caregiver. So I just didn't know if there was anything at all you could say about that. Is there someone folks could contact at Markey to be queued up for this study?
Right. So that's a good question. Based on my understanding, what's up there in the public domain, we do have an interim clinical trial for diarrhea management in neuroendocrine cancer patients, which is up and running both here at Markey Cancer Center and also at Vanderbilt University. So both teams here and at Andy, we are collaborating trial. We are not focused on the therapeutic trial, but I do understand that there is some data to support some cancer treatment based on the NTRADE. Again, I'm not very privy to the therapy trial for NTRADE. Having said that, if we are waiting, I would like to mention that we described our high-grade neuroendocrine cancer trials. We do have a very robust lineup for low-grade neuroendocrine tumor trials. In fact, we are going to be opening 3 first-in-human combination trials in low-grade neuroendocrine cancer. One is already up and running and enrolling. It's a triapine plus Lutathera study where we have already treated first 3 humans ever with this combination. And we are soon going to be opening another study where we are adding Zermelo, which works really well for carcinoid syndrome, diarrhea refractory to somatostatin analog. We are looking at the therapeutic intent of that combination because we believe that adding Zermelo might help prolong the disease control in addition to Lutathera. So that's the large phase 2 study that we developed, and it's going to be up.
Oh, very good. We seem to be losing signal with you, Dr. Chuhan. Slow internet.
A month and a half, and the third in be involving another DNA.
Okay. Yeah. Sorry, we kind of lost you to some slow internet there. So anyway, thank you very much. We appreciate your being here, and we'll see you at the Q&A panel.